Hello, this is Dr. Demarchena with Aaron Cohen, and we are beginning a series on the hemodynamics of valvular heart disease. So let's remember that the different pressures in the left ventricle and the aorta, because for our first lesson we're going to be talking about aortic stenosis. So the aortic valve sits at the outflow of the left ventricle. This is the left ventricle, little papillary muscles. And here's the muscle of the left ventricle. We'll just draw that like that. And the pressures inside the left ventricle are normally, let's say, 120 over 10. And in the aorta, the pressures are 120 over 80. And if we were looking at the pressure tracings in pressure volume curves, we'd see the left ventricular pressure tracing with left ventricular filling, akic. We'd have the isobolumic contraction phase. The aortic valve opens. There's the ejection of the left ventricle. The aortic valve closes. This is the isobolumic relaxation phase. And then diastolic filling again. And if we were looking at the aortic pressure tracing, we would see the diastolic decay of the aortic pressure. You'd see the increase in aortic pressure during ejection of the left ventricle, and then you'd see the notch that marks the closing of the aortic valve, and then you'd see diastolic decay again. And you can see that in the normal patient, the aortic valve or aortic pressure is exactly the same as the systolic left ventricular pressure. There's no pressure gradient across the valve. Now, when we start developing aortic stenosis, there is an occlusion or a stenosis of the aperture of the aortic valve, which causes an obstruction in left ventricular output. Now, there's several forms of aortic stenosis. The most common one, one second here. The most common one is calcific aortic stenosis. And calcific aortic stenosis is a disease that occurs more in the elderly. It occurs usually after the age of 60 to 70, into the 80s and 90s. And in certain situations, we can see it earlier. But in those patients, the aortic valve is trileaflet. So it has 3 cusps. And the aortic valve opens. If this was a long axis view of the valve, and this was the annulus, so this is the aorta here, and here's the left ventricle, the leaflets open by moving up and away, causing nice central laminar flow across the aortic outflow. In calcific aortic stenosis, the valve, just because of decay over time, sometimes because of enhanced calcification, like with renal failure and so forth, become very fibrous and stiff. And when that happens, the valve now has decreased excursion. And that doesn't allow the valve to open up totally, and it occludes the outflow of the valve. So the pressures in the left ventricle have to become very high in order to get blood past the small aperture. Now, in bicuspid aortic valve, which is the second most common form of aortic stenosis, seen more in younger patients in the 40s and 50s, is essentially a congenital abnormality of the valve that instead of having 3 cusps, it has 2 cusps. Now, when the patient is young, This doesn't cause an abnormality in flow because the valve leaflets are very pliable. But as they get older, these too begin to calcify and become fibrosed and rigid. And because of that, there's decreased excursion of the valve, and much like we saw in calcific aortic stenosis, there's an obstruction. And the third most common form of adult aortic stenosis is rheumatic aortic stenosis. And in the rheumatic aortic stenosis, there's a morphologically normal valve. So again, it would be tricuspid. But in after rheumatic fever, it's an intense inflammatory response and a continued persistent inflammatory reaction that causes the leaflets to become very inflamed. As they become inflamed, the commissures of the aortic valve fuse. And as they become fused, it narrows the aperture of the valve. So if we're looking here, whoops, it doesn't want to erase. Yeah. So the opening of the valve then is significantly reduced because of the fusion of the leaflets. So if we see this again in cross section, the leaflets are actually relatively pliable, although thick, but they can't. They try to open, but they can't because they're fused, and it causes the aperture to stay real low. And again, we have the same problem where we have to generate big pressures inside the left ventricle in order to overcome the hole in order to get flow past it.